Hello and welcome to lecture number 12 in our continuing series on drugs and human behavior. Today we're going to talk about antidepressant medications. I want to preface this discussion with the caveat that I think it's really important to carefully evaluate whether or not these medications are for a patient or for yourself or for a family member. They're certainly not without controversy and they're certainly not without side effects. That being said, depression is something that is treatable, and early intervention oftentimes appears to be an important part of limited treatment. These drugs are not, I don't think, meant to be taken for lifetimes. They should be taken for brief periods of time and then stepped off under the supervision of a physician. Their benefits, or potential benefits, really are related to the ways in which they affect and can mitigate the effects of stress on the brain. And that's one of the biggest problems with depression, is it seems to oftentimes be triggered by stress. And so if someone's going through a high stress time period, it's potentially a reasonable medication to add to try to buffer the effects of that stress. Research still needs to be continued in these areas, and again, I think it's something everyone should consider what's the best option for themselves and their loved ones, and not simply take pills because they seem to be the magic answer. I think these are things to be considered and thought about. So what we're going to talk about today is talk about sort of what the hope for antidepressant drugs are, or the claims about their use are, and then we'll introduce depression, talk about the pathophysiology of depression, give a quick introduction to the types of antidepressants we're going to be talking about, and then we'll break it down to sort of three different classes. The early antidepressant medications, which include the Tricyclics, the monoamine oxidase inhibitors, and what are called atypical antidepressant medications. Talk about selective serotonin reuptake inhibitors, which is the primary class of antidepressant treatment currently, and then talk about some dual action antidepressants, some of which work for depression, some of which work for other things, but all fall into this selective serotonin reuptake inhibitor or norepinephrine reuptake inhibitor category. Finally, summarize some of the efficacy of antidepressant medications and talk a little bit about what's in store for the future. So here's what antidepressant drugs we hope do. Is first of all to alleviate the signs, symptoms, and distress associated with clinical depression. So not just the sadness, but the anxiety, even pain can be involved in depression. So it's a pretty difficult thing to live with. Certainly plenty of people are at risk for depression. Women seem to be at greater risk for depression, but certainly men are at risk for depression as well. Obviously the ultimate problem with depression is it can lead to suicide. Men are far more likely to successfully commit suicide and are at the greatest risk for that, and it's certainly an area where we need to be paying more attention. The number of U.S. veterans committing suicide every year is beyond epidemic proportions. So we need to start to understand how to treat depression and how to prevent it in the first place. So antidepressant drugs are to alleviate depression, but also to relieve anxiety, either as a single diagnosis or as part of a comorbid anxiety-depression situation, to try to improve the lives of persons with debilitating depression, and to repair the neuronal damage associated with depression. And that's one of the things we're going to talk quite a bit about. And I think, for me, that's one of the benefits of some of these drugs, is they have the potential to try to stave off some of the damage caused by depression and by high periods of stress. So here's the biggest thing about depression, is these drugs are effective for some people, but mostly for severe depression. These drugs are not for the mildly sad, slightly depressed. They're probably not going to help those people. Some exercise, some cognitive behavioral therapy is probably really best for that class of people. These drugs are for the severely depressed. So if you look at the blue circles in this graph, and you can see the blue line, the HDRS score is a depression inventory. The Vertical axis is showing how much they've changed, so how much they've improved. What you can see is for those that have an HDRS score above 25, there is pretty marked improvement with these drugs for the most part. Obviously not all of them, but certainly we start to see a pretty great separation between placebo and the antidepressants at that point. So that starts to separate out at the greater the level of depression. And so the higher the level of depression, the more likely these drugs are to work. But these drugs are not effective for somebody who has a mild case of depression. So what is depression? Well, depression or major depressive disorder is a chronic, recurring, and potentially life-threatening illness. 4.5% of the total worldwide burden of disease and disability-adjusted life years is caused by depression. 70% of psychiatric hospitalizations and 40% of suicides are depression-related. Now, this is a really severe disease. About 9 to 10% of the U.S. population suffers from depression each year. 10% of men and about 25% of women will experience depression in their lifetime. And only about a fifth of those cases are adequately treated every year. So we've got to do more to treat these cases, find out what the best treatments are. And again, I want to make it very clear, these drugs are potentially useful for many people, but not everyone, and there are certainly alternatives available. So I think this is a conversation to have, for sure. So what are the characteristics of depression? It's an affective disorder with alterations of emotion or mood, substantial decreases in interest in pleasurable activities or an inability to even express pleasure, oftentimes sleep difficulties, clear fatigue or loss of energy, feelings of worthlessness or excessive guilt, and possible thoughts of death or suicide. From the Diagnostic and Statistical Manual of Mental Disorder, these symptoms are as follows. You have to have 5 or more of these symptoms present during the same 2-week period and represent a change, and at least one of the symptoms is depressed mood or loss of interest or pleasure. So depressed mood most of the day, nearly every day, is indicated by either subjective report or other report. Markedly diminished interest or pleasure in all or most all of activities. Significant weight loss when not dieting or significant weight gain. Insomnia or hypersomnia nearly every day. Psychomotor agitation or retardation nearly every day. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt. Diminished ability to think or concentrate or indecisiveness nearly every day. Recurrent thoughts of death, not just fear of dying, but thoughts of death. Recurrent suicidal ideation without a specific plan or a suicide attempt or specific plan for committing suicide. These symptoms must cause clinically significant distress or impairment, and the episode is not attributable to the physiological effects of substance use or some other medical condition. So these are the symptoms associated with depression, and you can see why they can be incredibly disruptive. The loss of the ability to concentrate, inability to sleep, fatigue. All of these are associated with depression. One of the important things to understand about depression is it's also associated with increased levels of cortisol. And cortisol is a steroid hormone that is particularly damaging to parts of the brain, particularly the hippocampus. And so we're going to talk about the potential for antidepressants to help stave off the effects of that increase in cortisol. We know that depression is often caused by some sort of high or sudden stress occurrence. So it's oftentimes a trigger for major depressive disorder. So what is causing depression? That is, what is the underlying pathophysiology of depression? Well, the classic theory of depression is simply that it's a deficiency involving neurotransmitters, in particular serotonin, norepinephrine, and or dopamine. And the idea was that if we could restore to normal the mood state by prolonging the presence of these neurotransmitters in the synapse, we can treat depression. So that was the idea, that we could increase mood by increasing neurotransmitter levels. The delay in clinical antidepressant effect, according to this classic theory, was due to changes in receptor sensitivity caused by chronic increase of neurotransmitter synaptic levels. There has to be a change in receptor sensitivity according to this view. Well, this is the classic theory, it's just simply a disruption in neurotransmission. But what we really think is going on is a disruption in what's called neurogenesis. So this is the neurogenic theory of depression. Existing neurons are able to repair or remodel themselves, and the brain is actually capable of making new neurons. We call this neurogenesis, and this is a brand new, within the last 10 or 15 years, discovery about the brain. So a variety of stimuli can actually damage neurons and decrease neurogenesis. In particular, stress damages hippocampal neurons. We also know that several factors are known to repair neurons and increase neurogenesis. Among them are antidepressant drugs. And so the idea is that antidepressants aren't there to just increase neurotransmitter levels, but actually to help repair and increase neurogenesis, and so actually get the brain functioning better once again. So there's been some attempt to identify the cellular processes in the hippocampus and the frontal cortex that are responsible for the protective effects of antidepressants. So this is a major focus of research in this area. One of these areas is looking at what's called cyclic AMP response elevated binding protein, or CREB, which unfortunately has nothing to do with the Krebs cycle, but it is the cyclic AMP response element binding protein. This activates genes that control the production of protein called brain-derived neurotrophic factor, or BDNF. BDNF is an important factor that has been recently talked about in a variety of areas about its role in important normal health and development of the nervous system. So you'll probably hear a lot about BDNF in other classes. So the critical importance of BDNF is it prevents neuronal death and protects neurons. We know that chronic stress can reduce brain-derived neurotrophic factor. The blood levels of BDNF are lower in depressed patients. And so by trying to solve this piece of the puzzle, we think we can actually stave off some of the damage caused by chronic depression. So here's the basic idea. Stress, injury, or illness may cause loss of neurons and some reduction in neurogenesis. So this can be due to death of a loved one, loss of a job, other significant stress, even birth of a child, marriage. All sorts of things can cause this kind of stress. Or even just some sort of injury, head injury, traumatic brain injury. So antidepressants then increase brain-derived neurotrophin factor, decrease those glucocorticoids that are responsible for that stress response, or part of that stress response, and then they increase neurogenesis and neuronal survival. So that's part of the puzzle. An open question is, what are the genetic and what we call epigenetic factors in depression? So somebody's underlying genetics. There certainly is heritability components of depression. And then the epigenetic factors are, has stress or substance abuse or brain injury cause some alteration in the genetic expression, which then results in depression or results in neuronal injury or death. Are some people more resilient to these effects? Are they less resilient? Are they more susceptible? What are the genetic factors? And these are some really important questions that hopefully we'll have the answer to sometime soon. So here's the basic idea. Depression is a consequence of some sort of stress event. Stress damages the brain and weakens its ability to recover. Antidepressants then relieve depressed mood by acting at the cellular level to promote neuronal survival and reverse stress-induced neuronal damage. The immediate effects of depressants is to modulate neurotransmitter synaptic levels, but the ultimate targets are intracellular molecules responsible for maintenance of neuronal health and plasticity. So the idea is to help repair the brain. So what are these antidepressants? Well, the tricyclic antidepressants are so named simply because of their chemical structure. We've talked about this previously, but often in the old school way of talking about drugs was by talking about their molecular formulas. Monoamine oxidase inhibitors inhibit the enzyme monoamine oxidase, thereby increasing the levels of dopamine and serotonin in the synaptic cleft. The atypical antidepressants, which would probably most of them now be called dual-action antidepressants. The SSRIs, or the selective serotonin reuptake inhibitors, do exactly what they describe. They block the reuptake of serotonin into the presynaptic neuron. Then there are dual-action antidepressants that primarily affect norepinephrine and serotonin. And then those that simply affect norepinephrine reuptake inhibitors. And so these are the different classes of drugs that we are going to talk about. The tricyclic antidepressants. So in this section, we're going to talk about the tricyclics, the MAOs, and the atypicals, because they're kind of an older class of antidepressants that are prescribed far less, but are still available and may be appropriate for some people, and they're certainly much cheaper than the SSRIs, but they are associated with pretty significant side effect profiles. So these tricyclics are a class of drugs that all have this characteristic three-ring molecular core. Probably the most well-known of these is amitriptyline, imipramine, and etc. These are all fairly similar in their overall profile. The tricyclics cause two pharmacological actions that account for both their therapeutic effects and most of their side effects. So they act by blocking the presynaptic norepinephrine and serotonin reuptake transporter proteins, so this is their mechanism of action. This is what provides their beneficial effects. Unfortunately, they also block the histamine and acetylcholine receptors, which is responsible for most of their side effects. So we get sedation and cognitive dysfunction that might occur. The anticholinergic actions in these drugs can be somewhere between bothersome and incredibly toxic. The nortriptyline and disipramine seem to be best. They seem to have the least anticholinergic and antihistaminic properties. All tricyclic antidepressants have three significant clinical limitations. They have very slow onset of action, they have significant side effects, and in overdose they are cardiotoxic and potentially fatal. And so providing somebody who's depressed with a drug that can kill them, probably not the best course of action. Now, if this is a drug that they respond well to and they can be trusted with them, and the side effects aren't too bad, it's certainly something to think about. So some of the side effects of these tricyclic antidepressants occur because of their anticholinergic and antihistaminic and a little bit from their antiadrenergic actions. So there are certainly cognitive and memory effects. That's the anticholinergic effects, the neurological effects, cardiovascular effects, gastrointestinal effects, sexual side effects, endocrine effects, allergic reactions, etc. So what to conclude about the tricyclics? They're no more efficacious than SSRIs. The potential side effects and toxicity are certainly much greater than SSRIs, and SSRIs have a higher rate of patient comfort and compliance. MAOIs are monoamine oxidase inhibitors. Monoamine oxidase is an enzyme that regulates the amount of monoamine neurotransmitters, norepinephrine, dopamine, and serotonin in the body and brain. Three classic MAOIs were developed in the mid-1950s. Their use is limited by potentially fatal interactions when taken with certain foods and medicines. You've probably all looked at cough medicine or almost any over-the-counter drug, and it says do not take if you're taking monoamine oxidase inhibitors. So any drugs that are adrenaline-like that might be found in a nasal spray or anti-asthma medications or cold medicines are potentially fatal. And any foods that contain tyramine are also potentially fatal in combination with monoamine oxidase. Despite all that, interest in MAOIs has remained strong. They can be as safe as SSRIs. They can work in many patients who respond poorly to either tricyclics or SSRIs, so they are potentially a good choice for some people. They're particularly effective drugs for the treatment of a wide range of depression. So people who are non-responders to SSRIs, these might be a good choice. The atypical antidepressants include protoline and amoxapine. The protoline offers few therapeutic advantages, can cause seizures, and can be fatal on overdose. The amoxapine may produce Parkinsonian-like effects as a result of postsynaptic dopamine receptor blockade. Not generally a first choice, and overdose can certainly be fatal. The other atypical antidepressants I want to talk briefly about are trazodone, clomipramine, and bupropion. Bupropion is used quite a bit in our modern times. So trazodone is as efficacious as the tricyclics. It has a unique mechanism. Unfortunately, it can cause drowsiness and priapism, which is an erection that lasts for more than 4 hours. It is less anticholinergic and therefore causes less cognitive dysfunction. A new formulation was approved in 2010 for treatment of major depressive disorder in adults. The daytime sedation is sometimes problematic, so it can be taken at night. Clomipramine is a tricyclic antidepressant that inhibits mainly serotonin reuptake with some norepinephrine potentiating effects. It's classically indicated for obsessive-compulsive disorder and seems to be equal to Tricyclics, but again limited by its side effects. Bupropion, which is Wellbutrin or Zyban, primarily affects the dopamine reuptake inhibition. It certainly affects the dopamine transporter. It has an anti-craving action, so that's good. It has been tried for treatment for people who are quitting some drugs like cocaine, and it's certainly been approved for use for people who are trying to quit smoking, which is what Zyban is for. It can cause anxiety, restlessness, tremor, and insomnia. It's used to treat depression, attention deficit hyperactivity disorder, and nicotine dependency. Unfortunately, it can cause anxiety and seizures, but can potentially improve sexual function, and it's certainly not effective for panic disorder. So next, we'll spend some time talking about the selective serotonin reuptake inhibitors. This is the class of antidepressant drugs that are primarily used at this particular time. These are all potent blockers of the presynaptic transporter for serotonin reuptake, so they block reuptake or inhibit the reuptake of serotonin. The degree of blocking of reuptake for other neurotransmitters varies greatly. These include fluoxetine, sertraline, paroxetine, fluvoxamine, escitalopram. So these are all selective serotonin reuptake inhibitors. We'll talk about these individually. Prozac's obviously the oldest and most commonly prescribed. Paxil is often used for treatment of generalized anxiety disorder and panic disorder, and has a pretty significant affective blunting effect in some people. And then citalopram and escitalopram seem to be sort of the newer go-to antidepressants in this class. There are two newer SSRIs that are kind of too new to discuss in great detail. Vilazodone has a dual serotonin action. Doesn't appear to have any therapeutic advantages over other agents. Vortioxetine is a multimodal antidepressant which inhibits serotonin reuptake. It's an agonist of serotonin 1A, a partial agonist of serotonin 1B, and an antagonist of 5-HT3, 1D, and 7 receptors. So keep an eye out for those. They may demonstrate some efficacy. One of the big problems with SSRIs is they inhibit some of these cytochrome P450 enzymes. So we get this enzyme inhibition. So it's an important clinical consideration for people who are taking other medications, things like other cytochrome P inhibitors, hydrocodone, or birth control. All of these drugs can have some effects on some of these drugs can have some effects on those other drugs. So you always want to check and see what kind of drug interactions there might be. In particular, fluoxetine seems to have the most significant cytochrome P inhibition effects, as does fluvoxamine. Citalopram and escitalopram have very few cytochrome P enzyme inhibition, or very little cytochrome P enzyme inhibition. In particular, you can see that cytochrome P452DG is the most significantly affected by this class of drugs, which is also the enzyme which is necessary for converting hydrocodone into codeine. The clinical differences amongst these individual SSRIs appear to be minimal. They appear to be about as equally effective and are about as effective as older antidepressants. Importantly, SSRIs are not fatal in overdose. There are some concerns with SSRI therapy, which include plenty of people who are treatment resistant and the potential for what's called Serotonin Syndrome. Potential side effects of all these drugs include sedation, some apathy, some sleep disturbance, possible cognitive impairment, physiological symptoms, possible weight gain. Some have sexual side effects, including inability to obtain an erection or an inability to orgasm, which doesn't seem to help anyone's depression.
Some people report it as a benefit, that is, that delayed orgasm seems to be somewhat of a benefit for some people. So keep in mind that that's potential side effects. People who are at risk for bipolar disorder these may trigger manic episodes, and certainly drugs like Paxil have significant withdrawal effects. All of these drugs contain a black box warning about the potential for suicidal ideation in children and adolescents, which we will talk about in more detail when we get to talking about adolescent psychopharmacology. Quick warning about Serotonin Syndrome. High doses or combinations of drugs can produce exaggerated responses to these drugs. These include altered cognition, which can include disorientation, confusion, hypomania, delusions, sort of feelings of losing it, some behavioral alterations, including agitation and restlessness, some autonomic symptoms, including fever, chills, sweat, diarrhea, hypertension, and tachycardia, some neuromuscular impairment, including ataxia and hyperreflexia, and this usually can resolve within 24 to 48 hours, provided that they reduce whatever amount of drug they've taken. One problem with taking these drugs is they are associated with what's called Serotonin Discontinuation Syndrome. There are 6 core somatic sets of symptoms that the acronym FINISH will help you remember. They include flu-like symptoms, fatigue, lethargy, malaise, chills, and headache, insomnia, gastrointestinal systems, including vomiting and diarrhea, potential imbalance, so dizziness, vertigo, ataxia, sensory disturbances, so sensation of electrical shocks in the arms, leg, or head, and hyperarousal, so anxiety or agitation. I can tell you, I was out of my antidepressant. I take escitalopram or Lexapro, and ran out at some point, and I can tell you the flu-like symptoms and imbalance, all of that really are problematic. And once I got back on them, it resolved that issue. So I'm hoping to eventually step off them. You have to step off these drugs slowly, or just simply power through the serotonin discontinuation syndrome. So SSRIs and suicide, here's where we get some question about whether or not they improve or don't improve risk for suicide. You certainly get reductions in thoughts of death, which are an important part of reducing risk for suicide. You can see there isn't much reduction in suicidal ideation. I mean, there's a little bit. And there is just simply not much room to move the needle on attempts or completion. It's the same thing with suicidal ideation. It reduces from about 4% down to 0%. So that's a significant improvement, but without treatment it gets it almost to 0 as well. So probably depends, of course, on the level of depression, etc., but at least reducing those thoughts of death seem to be an important part of this. So let's take a look at some specific SSRIs. Prozac or fluoxetine is the first SSRI-type antidepressant, and the first non-tricyclic antidepressant that's considered a first-line antidepressant. Has similar efficacies to tricyclics, and is often the first to be prescribed. In fact, oftentimes insurance companies insist that it's the first to be prescribed. It has a 2 to 3 day half-life, but it has an active metabolite that has a half-life of 6 to 10 days. So it takes almost 3 months to reach steady state. So this is one of the biggest problems with this class of drugs, is it takes so long to get to the point that you're taking in as much as you're putting back out. And so you oftentimes have to stay on these drugs for quite a while to determine whether or not they're effective, which can be problematic. Side effects include serotonin syndrome, anxiety, insomnia, and sexual dysfunction, particularly inability to obtain an erection. Sertraline or Zoloft, it's 4 to 5 times more potent and selective than Prozac. Reaches steady state much quicker, 4 to 7 days. Has a shorter acting and less active metabolite. Appears to be effective in treating depression, dysthymia, and some anxiety disorders. It's reportedly effective in comorbid PTSD and alcohol dependence, and has few anticholinergic, antihistaminic, and adverse cardiovascular effects, as well as low risk of toxicity and overdose. Pretty good choice for those who having a pretty severe depression. This is a pretty safe drug for them. Paroxetine or Paxil. Personally, this is one of those drugs that I think works very well for people who have very disruptive anxiety disorders. But it would not be my first choice for major depression because it does seem to have some serious affective blunting in some people. So it's FDA approved for treating depression, obsessive compulsive disorder, and panic disorder. Should not be used during pregnancy at all. It seems to be more selective than Prozac, and again has about a 24-hour half-life. Fluvoxamine is a derivative of fluoxetine. It's available for treatment of obsessive compulsive disorder. Appears to be an effective antidepressant, but again, it appears to be best in OCD, PTSD, panic disorder, or social anxiety disorder. These are off-label uses, but they are used in those areas. Citalopram or Celexa. It's been available in the U.S. since 1998. Used for treating major depressive disorder, social phobia, obsessive compulsive disorder, and panic disorder. Has about a 33-hour half-life, which is much longer in the elderly. Same effects as all other SSRIs, but does not include the drug interactions because it does not inhibit the hepatic drug metabolizing enzymes. So this may be an important consideration for people who are on other drugs that you don't want to have interactions with. Escitalopram or Lexapro. This is an active isomer of citalopram. It's twice as potent, so you can use half the dose. Seems to be equivalent in treating panic attacks in the elderly, but again, careful with prescriptions in the elderly because of that extended half-life. The dual-action antidepressants expand actions at 2 different synaptic sites to improve or maintain efficacy while limiting side effects. Nefazodone has been withdrawn, so we won't talk about it. Milnacipran, venlafaxine, duloxetine, and mirtazapine are drugs that are currently available. So let's start with talking about milnacipran. It blocks norepinephrine and serotonin reuptake, blocks the NMDA-type glutamate receptors in the spinal cord, contributing to its analgesic action. So it is approved only for that use. The FDA has approved this drug for treatment of fibromyalgia, but not as an antidepressant. And so it is primarily for chronic pain. Effexor is a mixed serotonin, norepinephrine, 5-HT, and norepinephrine reuptake inhibitor. It's not anticholinergic or antihistaminic. Has little or no cognitive dysfunction or sedation, but can cause increase in blood pressure. And there is a longer-acting version of this for treatment of generalized anxiety disorder. Prestique was approved in 2008 for the treatment of major depressive disorder. Has an 11-hour half-life. There was some attempt to get this approved for treatment of hot flashes in postmenopausal women, but that was refused. Cymbalta appears to reduce both depression and anxiety. Also seems to work well to reduce the physical symptoms of pain, backache, joint and muscle pain, back and shoulder pain, particularly those associated with depression. Depression has like an achy component to it. There is potential for this to be used where pain and depression occur comorbidly, and can be used for generalized anxiety disorder and has a half-life of about 12 hours. Fortunately, weight gain, sexual dysfunction, and hypertension have not been reported as major problems with this particular drug. Remeron increases norepinephrine and 5-HT transmission via a complicated presynaptic mechanism. Causes a pretty high histamine blockade, so it's highly sedative. Keep in mind when we talk about histamine blockades, Benadryl is primarily a histamine blocker, and if you think about what Benadryl is like to take, it makes you very sleepy, and that's what these drugs are like. So just keep that in mind. This drug has been associated with increases in appetite and body weight, and has a pretty long half-life of about 20 to 40 hours. Strattera is a drug we'll talk about when we talk about ADHD. It is a norepinephrine reuptake inhibitor. It's used for ADHD in children and adults. Has been used as an adjunct in fibromyalgia. Appears to be antidepressant and analgesic, and has shown to be effective in PTSD. Primarily, it's used for ADHD and comorbid depression. So how good are antidepressants? That is, how efficacious are they really? Well, there's a very large study called the STAR-D study. The goal was to determine the effectiveness of depression treatment for major depressive disorder and primary and specialty treatment centers. We're talking about 3,000 participants at 41 clinics. About 2/3 of participants were able to achieve remission if they did not withdraw from the study. Unfortunately, the dropout rates were between 21% and 42%. So you have to consider that the people who remained in the study are probably the ones who were getting the most out of these antidepressants. So while we're talking about a 2/3 reduction in depression for those that stayed in, keep in mind 20 to 40% of the original group dropped out. So we're probably talking about a 50% efficacy rate, somewhere in there. Overall, there didn't appear to be any that was any superior to others. One of the biggest problems in conducting studies on these is there are very large placebo effects. We talked about this previously about how to design studies, and one of the things you have to do is a placebo run-in period. And what's done in those is you give people placebo for a first time period, and anybody who gets better is dropped from the study because you know that they're going to respond only to placebo. And then you can actually get a much better determination as to whether or not antidepressants are effective by getting the people who don't respond to just the placebo. So where do we go from here? Well, we certainly need to develop the genetics in this area. So can we use genetics to help guide therapy? We certainly need more effective medications with a reduced side effect burden. I think it's really important to be mindful of the side effects that these drugs can cause. These are not, again, not drugs to be taken lightly. So you want to be very cautious and think about whether or not these are for you. But again, I want to also make it very clear, these can be very effective for some people, and certainly living with depression is not the answer. So these are probably better for some people than just simply living through it. There are other alternative treatments you can explore too, but no depression should go untreated. I want to make that very clear. So what can genetic testing do? Well, genetic testing might be able to help us identify deficits in drug metabolism that predict drug interactions that occur with many antidepressants. Recent interest has centered on how genetic alterations may influence the clinical response or the lack of response to these medications. There are plenty of people who don't respond at all to SSRIs, and so we're going to explore some alternative treatments in the next set of discussions. So in the future, augmenting agents might be used. So drugs like modafinil, it's a non-stimulant wakefulness-promoting drug used to combat daytime fatigue in patients with narcolepsy. It's also been shown to improve working memory and fluid intelligence. Or modafinil is a sort of longer-lasting isomer formulation of modafinil. Lamotrigine is an anticonvulsant and mood stabilizer, which might help. Two atypical antipsychotics, Abilify and Seroquel, have been demonstrated to have antidepressant activity for, again, people who are non-responsive. They are now approved by the FDA for treatment of treatment-resistant depression. So if you look at placebo versus Abilify, the minimal or non-responses came mostly in the placebo condition, and about twice as many people had a robust response to Abilify as to placebo. And again, you start getting increases in differences between placebo and Abilify in these stronger responses. But again, you should also notice that about 40% of people still did not respond to Abilify. Ziprasidone, again, over a period of 6 weeks, seemed to improve compared to placebo. There are some natural substances that may have antidepressant properties. Omega-3 fatty acids, EPA or DHEA, all of these have potential neurogenic effects. Certainly DHEA has been shown to be an important component for neural development in kids. Folate, this is controversial as a treatment for depression. SAMe, its efficacy appears to be similar to the Tricyclics. St. John's wort, careful with St. John's wort. Certainly don't take if you're going to take it with other antidepressants. And make sure you discuss this with your doctor because it does have a number of drug interactions. And so be very careful of this one. There are other options too, DHEA or dehydroepiandrosterone. We're going to talk more about that when we get to talking about older adults, but this may be effective in HIV-related depression. There are some studies that demonstrate its potential efficacy for that. So what do we conclude? Well, there is certainly need for significant resources to come up with better alternatives to investigate the genetic and neurogenic issues in depression. Depression should never go untreated. We just need to find the best treatment. So we certainly need more funding in this area. The best research in this area is always done by people who have no skin in the game, as it were. So that is, who have no financial incentives. So this is where I think it's important that we get funding for independent research. Again, there are many non-pharmacological treatments for depression in use and under investigation. These include things like electroconvulsive therapy, transcranial magnetic stimulation, electrocortical stimulation. So these are potentially areas where we can have non-pharmacological interventions, and these certainly have demonstrated to be effective for people who are non-responders. Certainly not something to be done lightly, but a number of people have talked about how these alternatives have been lifesavers for them. So we'll be discussing that in our next series.